So we'll be speaking about optimizing the CUVIS robot in the OT. So we'll not be discussing the pros and cons of any system, but we'll be discussing how to optimize the CUVIS robot. Now, since morning, we have been discussing that how robots are improving the functional outcome by decreasing the outliers in terms of alignment, better component positioning, and you can see that there is this intra-op dynamic referencing for gap balancing. Okay, every system has got all these three things, and it's up to the surgeon that how you use your system to get the best out of it. Now we have seen that there is evolution of prosthesis. We are getting better implants, different sizes of implant, so that it can fit the patient anatomy in the best possible way. What is a robo? Robo is actually evolution of instrumentation. Okay, so it is a tool in your hand so that you can do the surgery properly. Whether you believe in mechanical alignment, whether you believe in restrictive kinematic alignment or anything, whether you believe in tight joint, loose joint, whatever you believe in, the robot helps you to perform that. So you must know your robot properly to get best out of it. All the robot, they have all the features, but it's up to the surgeon how to utilize it properly. Now, when you talk about optimizing the robot in OT, that means you want to improve the efficiency, you want to decrease the time taken for the surgery, you want to improve the accuracy, and you want to reduce the complications. Now, if we talk about CUVIS robo, it's a CT-based robo. So one of the advantages is that you have a pre-op assessment of the patient's anatomy, and you can accordingly plan a day before so that there are no real surprises. Okay? You can identify what are the osteophytes present, whether there are any posterior osteophytes present or not, which has to be removed. Are there any bone defects? You can accurately assess the implant size and the placement. So you spend 5 minutes a day before and you have a fair idea about the size of implant you will be using, the placement of the implant. You can plan on the CT scan that how you are going to rotate the implant. So it has got nothing to do with posterior condylar axis. It has to be with the patient's native rotation. That thing you can easily assess on the CT scan on the axial cuts. Then at the end, you can get a picture like this where you have an idea about the resection which you are going to take, the size of the implant, and if there are any bony defects, you also have an idea about that, and you can either keep some additional implants for managing the defects, if you need any bone grafts or cement. So all these things you don't have to decide on the table, but this is there before the surgery. Now, intra-op optimization, well, we all know that how you have to put what precautions you have to take to put the tracker pins. Better to put them in metaphyseal region and don't violate both the cortices, otherwise there's a real possibility of fractures later on. And mind you, these fractures, mostly they don't occur immediately. These fractures are seen 3 to 4 months after the surgery. Secondly, it's very important that you register these, you map these points properly. Don't register on the osteophytes or else you will have some discrepancy. After registration, it's better if you remove the osteophytes, the cruciates and menisci before the gap assessment. That way your gap balancing will be much better. Now, once you have done the registration, then you get a picture like this. Every system has got a different sort of picture, but basically it is the same thing. Now, here you have the option to place your implant properly. Now, in tibia, you can just either distalize it, or you can move it more proximal, or you can give it a bit of varus or valgus depending upon your alignment philosophy. But the major thing, the main play happens in femur, where you can either distalize it, you can keep it more proximal, you can rotate it both in longitudinal axis, either internal rotation or external rotation, or in the horizontal axis you can give flexion or extension. So that is your judgment, a surgeon's judgment, and for that you have to know your subject, you have to know your knee replacement philosophy, the principles, and how you are going to use your system for that. So we talked intra-op optimization. You have to optimize the pin placement. Now, as it is a totally active system, so you have to place the pins properly so that the soft tissues retraction is proper and they don't come in the way of robotic arm. This, the tracker also have to be placed away from the robotic arm. And ideally, one should always use a disposable burr and array ball for better accuracy. Post-resection, if you want, you can do cut verification, but after a few cases, you realize that it's quite accurate, you stop doing it, and then you can again do the gap check with trial implants. But there are times when your clinical assessment doesn't match the numbers on the robo. Well, that's your judgment, because ultimately it's your judgment which is going to decide what is good for the patient. Thank you for your